You know the scene. It's a movie staple, always played for high drama. Someone wakes up, they're completely disoriented, terrified. They look around in their personal history, who they are, how they got there. It's gone. That sudden, acute onset amnesia is, I think, maybe the most terrifying neurological event you can witness.
It absolutely is, and that alarm is justified. I mean, you have to immediately rule out something catastrophic, like a stroke.
Right.
But here is the profound riddle at the heart of our sources today. The most common, yet maybe the most mysterious cause of this dramatic, sudden memory loss is something called transient global amnesia, or TGA.
And that is the core mission of this deep dive. We're using the source material you shared, which really spans everything from clinical diagnosis to cutting-edge computational theory.
Right.
And we want to arm ourselves and you, the listener, with a key insight.
Right.
How do you distinguish this temporary, benign, but dramatic blackout TGA from the urgent, dangerous mimics that need immediate action?
We're going to get into the specific neurological architecture that fails during TGA, focusing on that critical disturbance in the hippocampus, and ultimately why this particular form of memory loss is a transient failure, not a permanent erasure.
Okay, let's unpack this. We have to start by setting the stage. Memory isn't just one thing. When it fails, we need to know exactly what part of the architecture is affected.
Precisely. The main system at stake in TGA and most acute amnesia is what we call declarative memory.
Okay.
Think of this as the explicit memory, the information you can consciously access and, declare to someone else.
And this system immediately splits into two really critical subtypes. First, there's episodic memory. This is your personal autobiography.
Yes.
It's the re-experience of past events, remembering your wedding day or a conversation you had last night.
The time-stamped memory. Loss of this type is what immediately raises suspicion of pathology because the hippocampus is just essential for forming and consolidating these specific personal events. And critically, TGA principally affects this episodic memory.
Then the second type is semantic memory. I kind of think of this as the general knowledge database, the facts.
That's a great way to put it.
Knowing the capital of Canada or what a wrench is used for.
Exactly. That fact-based knowledge is widely distributed throughout the cortex. And here's the key clinical point. Semantic memory typically remains largely intact in TGA patients. They still know general facts. They know how the world works.
And we contrast both of those with non-declarative memory, the implicit stuff.
Right. This is knowing how to do things. Motor skills, conditioning, habits.
Playing the piano.
Exactly. And that separation is essential because it shows us that the procedural parts of the brain are still functional. The classic heartbreaking example is Clive Waring.
Oh, yes.
Despite losing his declarative memory almost entirely, he was living in a 7-second loop, moment to moment. He could still play and conduct complex music flawlessly. His skill remained even when his personal narrative was completely erased.
Which really underscores that TGA is an issue with retrieving or creating personal history, not some kind of global mental shutdown. Now, let's look at the when of memory failure. The two terms we see everywhere are retrograde and anterograde.
Right. Retrograde amnesia is memory loss for events that were acquired before the onset of the amnesic event.
And anterograde amnesia is the inability to form new memories after it starts. They just can't hold on to new information.
And this is where TGA gets its defining characteristic. It involves dense anterograde amnesia. The patient is stuck in a loop.
The classic, where am I?
Exactly. They'll ask, where am I? And you tell them, and then 2 minutes later, they ask the exact same question. The retrograde amnesia in TGA is usually limited, maybe the hours or days before, sometimes years. But remote memories, the ones from decades ago, they stay intact.
So the most persistent, maybe the cruelest part for the patient, is that after the episode is over, the memory of the TGA period itself is usually a permanent, unrecoverable gap. It just never got consolidated.
A total blank space in their personal history.
Okay, let's put the spotlight directly on TGA now. Clinically, it sounds absolutely terrifying, but as you said, it is profoundly short-lived. What does the presentation actually look like in a real, emergency setting?
It is strikingly stereotypical. The incidence isn't high, maybe 3 to 10 people per 100,000 annually, typically around age 60 or 70. By definition, it has to resolve within 24 hours, but usually it's much quicker, often 4 to 6 hours.
And that patient repeatedly asking the same question, that's the absolute hallmark, right? It's driven by that acute inability to form new episodic memories.
Yes. And for clinicians, the most important takeaway is what is absent. The key diagnostic criteria emphasize that the amnesia must be isolated.
Nothing else wrong.
Nothing. There can be no clouding of consciousness, no loss of personal identity, and crucially, no focal neurological signs, no weakness, no sensory loss, no visual field defects. The pure presentation is the key to this being a benign diagnosis.
That distinction, pure amnesia, no other symptoms, is so critical because it directs you away from thinking about a stroke. What's fascinating is that the source material points out that specific activities seem to precipitate TGA in a huge number of cases.
Up to 89%, which suggests a functional trigger. We see activities that raise emotional or physical pressure.
Like what?
Physical exertion, like heavy gardening or lifting something. Emotional or psychological distress, getting difficult news. An intense argument. And even sudden temperature changes, like plunging into cold water.
And I saw there was a noticeable gender split in the triggers.
Yes, there is. Men are statistically more often triggered by physical exertion, whereas for women, it's more frequently associated with emotional distress. It points towards some kind of physiological response to acute stress that targets this vulnerable part of the brain.
Speaking of vulnerability, let's talk imaging, because this is where the paradox really hits. If someone rushes to the hospital during the amnesic episode, the standard MRI usually comes back normal.
Which is good. I mean, it rules out immediate structural damage, but it's initially very confusing. The astonishing fact about TGA is that the characteristic lesions, the temporary evidence of neurological disturbance, only show up on special imaging, diffusion-weighted imaging.
When?
12 to 48 hours after the patient has completely recovered.
Wait, a lesion that appears only after the patient is better? That completely defies the logic of, well, all of acute neurology.
It's highly unusual, but it's a huge clue. These tiny spots are typically localized to the CA1 region of the hippocampus. This delayed appearance reinforces the idea that TGA isn't caused by immediate tissue destruction like a stroke, but by a temporary physiological disruption that just takes time to show up on a scan.
Which leads us directly to the prognosis. And this is the greatest reassurance we can offer about this whole frightening event.
Absolutely. The outlook is overwhelmingly favorable. Recurrence is low, less than 5.5% of patients in large studies. And here is the core takeaway the source material wants to emphasize. Having TGA does not increase your long-term risk of stroke, seizures, or cognitive impairment like dementia.
In fact, I saw one major study showed TGA patients actually had lower rates of later ischemic events.
Yeah.
That really decouples TGA from being seen as a kind of mini-stroke.
It absolutely does. The lack of increased stroke risk suggests this isn't a true vascular occlusion. It forces us to look at the vulnerable mechanism. Why that CA1 region?
It sounds like it's some kind of metabolic bottleneck.
It is. The CA1 region is a critical output relay, and it has naturally diminished perfusion, which makes it susceptible to metabolic stress. It's also loaded with NMDA receptors, making it prone to something called excitotoxicity.
Which is what, exactly?
Basically, nerve cells overfiring and dying when they're stressed.
So those physical or emotional stress triggers the heavy lifting, the difficult news that links right into this metabolic vulnerability.
The leading theories reflect this. One is vascular. The Valsalva maneuver, which happens when you strain or cough can, increase intracranial pressure and temporarily disrupt blood flow, briefly starving that CA1 region.
And the other one?
The other major hypothesis is cortical spreading depression, or CSD. This is a wave of temporary cellular unresponsiveness that sweeps across the cortex. It can be triggered by stress hormones, and it just pauses the memory consolidation process.
Now we have to shift to the critical clinical duty. Quickly telling TGA apart from its dangerous mimics. You can't just assume it's TGA until you've ruled these other things out.
Exactly. The first, most urgent one to rule out is a strategic ischemic stroke, which can affect the hippocampus.
Okay, so what's the fastest way to clinically tell them apart?
A stroke almost never presents as pure, isolated amnesia. Stroke lesions typically cause other focal neurological deficits.
Even subtle ones.
Even subtle ones. A minor visual defect, a little weakness, a sensory change. Recovery is also not typically within hours, and crucially, stroke patients usually have traditional cardiovascular risk factors that TGA patients often lack.
And the key imaging distinction, just to reiterate, stroke lesions are visible during the amnesic episode.
Acutely, yes, whereas TGA lesions only appear hours later after everything is resolved.
Right, timing is everything. Next on the list of mimics is transient epileptic amnesia, or TEA.
Yes, this is often mistaken for TGA initially.
So what profile tells us it's actually epilepsy?
Recurrence and timing. TEA attacks are highly recurrent. A patient might have 15 attacks a year, whereas TGA is usually a one-time thing.
And shorter, right.
Much shorter, often just 15 to 60 minutes, and 70% of them happen right upon waking. Plus, since they're linked to the temporal lobe, patients sometimes report other features like strange smells or brief automatic behaviors.
And what about long-term memory?
TEA patients often have persistent, subtle memory problems, especially with remote autobiographical memories, even between the acute attacks. TGA patients, once they've recovered, are typically cognitively normal.
Okay, finally, the most conceptually different mimic. Psychogenic or dissociative amnesia. Memory loss driven by severe psychological trauma.
This is a fundamentally different mechanism. The critical distinction is the scope of the memory loss. In dissociative amnesia, retrograde amnesia is predominant, and the patient may lose personal semantic memory.
Meaning they forget who they are.
Literally, they forget their name, their address, or they don't recognize their immediate family members.
So they lose their personal identity, which TGA patients always retain.
Precisely. They lose the fundamental facts about themselves, but, and this is key, they often maintain the ability to form new memories. Their anterograde memory is typically intact, which is the exact opposite of TGA.
That's a complete inversion of the TGA pattern.
It is. The case reports are compelling, like the 41-year-old man who, after a minor trauma, lost 20 years of memory. He didn't recognize his wife or children. His recovery was long and slow, taking 8 months, which is a world away from the 24-hour limit of TGA.
Okay, before we jump into the deepest theory, let's just quickly check off post-traumatic amnesia, PTA, and drug issues.
Sure. PTA requires a history of a physical head injury, and it involves a whole host of other cognitive deficits, like attention problems, not just isolated memory loss.
That's toxic or drug-related.
That's rarely pure either. It usually involves a fluctuating level of consciousness or other neuropsychiatric signs like paranoia or unstable vital signs. Again, the purity of TGA is its greatest defining factor.
Okay, so we've covered the clinical picture. Now let's go deeper. You mentioned that TGA is a failure of access, not erasure. This feels like the crucial conceptual shift. If the tissue isn't destroyed, the memory must still be there, right?
That's the consensus among computational neuroscientists. The principal limiting factor in our memory performance is not erasure or storage capacity. It is retrieval interference. The memory trace is often stored indelibly. It's there, we just can't get to it.
It's like having a gigantic library, but the entire card catalog system goes down for 6 hours. The books are all safe on the shelves, but you can't look up the location of anything new, and you can only find your most used ancient textbooks.
That analogy perfectly illustrates the key value memory system, which is a framework that connects the biological process to machine learning models like transformers. This system separates the index from the content.
So walk us through the brain's version of the index card in the book.
Well, the memory is split into two components. The keys are the representations used for retrieval. Think of them as the index cards or the specific address. Their main function is to maximize discriminability.
Meaning what?
Meaning they ensure that two similar memories don't accidentally get confused, allowing you to pull up a highly specific memory trace.
And the values.
The values store the actual memory content itself, optimized for fidelity. They are the book's text. The brain seems to implement this division of labor through its complementary learning systems.
Which are?
The hippocampus stores the keys, that sparse conjunctive index highly optimized for discrimination. The neocortex stores the values, the actual semantic content, and generalized specifics.
This instantly makes sense of so much of our daily memory experience.
It does. The tip of the tongue phenomenon is explained by this. You've matched the query to the key, you know the information is stored, but the critical link to retrieve the full value is just temporarily failing.
In bringing it back to TGA, the profound implications that TGA is likely a temporary physiological shutdown of the hippocampal indexing system.
The key mechanism.
Right, probably due to that transient stress in the CA1 sector. But the memory stored in the neocortex, the values, they remain intact and safe.
The memory trace itself remains stored. It's sometimes referred to as a silent engongram. The retrieval access is just transiently lost. Computational simulations have even shown that if you artificially boost the signal of the keys in a neural network, you can instantly recover seemingly forgotten tasks without any retraining. It was always there, just inaccessible.
So the ultimate takeaway here is that TGA represents a temporary failure of the retrieval mechanism, but the integrity of the memory storage, the very foundation of the self, is maintained. It's a blackout, not an erasure. That terrifying symptom is just a temporary failure in accessing your personal index.
And this highlights how reliant the coherence of our entire personal narrative is on that one tiny high-demand structure, the hippocampus. It's the gatekeeper, and when that gate temporarily jams, the results are dramatic.
Which raises an important final question for you, the listener, to think about. If the hippocampus is primarily optimized for high discrimination, for preventing any overlap between similar memories, thus ensuring a reliable index, that function necessarily makes the index highly sensitive to disruption. So should we prefer the brain strategy of high discriminability with the occasional dramatic failure of access we call transient global amnesia? Or would we trade that occasional blackout for a system optimized for constant access, even if the result was continuous low-level confusion between every similar event you've ever experienced?
The occasional jam versus constant static, it really makes you think about the hidden trade-offs our brain architecture is making every single day.
Something to think about next time you struggle to pull up that forgotten name. Thanks for diving in with us.